Today we're going to discuss part 7 of our approach to chronic dyspnea. So, as of now, we've covered symptom analysis, we've covered the examination of the pulmonary system, analysis of pulmonary function tests, and examination of the cardiovascular system, excluding murmurs. At this point, you have a fairly good idea about the patient's likely tissue distribution of pathology, and you have a diagnostic frameworks that allow you to analyze and dissect your way through the likely physiological abnormalities that the respiratory or the cardiovascular system have. However, there is another modality, that is 2D echocardiography, that allows you to further dissect through the intricacies of the physiological abnormalities in the cardiovascular system. And from the point of an internal medicine doctor or a person who does not specialize in cardiology per se, the interpretation of an echocardiogram can provide vital information to differentiate the different causes of shortness of breath in a person with a multi-system disease, say rheumatoid arthritis, systemic sclerosis, a multi-system infection. Okay, so it is important for the non-cardiologist as well. So we'll begin with a review of the core concepts of the physics behind 2D echocardiography and image formation, although I'll be going into this more in detail in a separate series. Then we will derive the measurements that need to be taken in order to assess LV systolic function for this video. Okay, so let's start. So we've got two echo probes here. The one on the left is going to be a B mode acquisition, and the one on the right is going to use the Doppler phenomenon. So the speed of sound of ultrasound waves through our soft tissue on average is 1540 meters per second. Okay, because we know the speed of the ultrasonic wave that we are producing, and we can actually measure the amount of time it has taken to reach this tissue interface here, okay, then get reflected back towards the probe and then reach back to the probe. That time, if it is a time t, can be used knowing the velocity to determine the distance from the probe here to the interface between tissue number 1 and tissue number 2. Okay, similarly another interaction will occur at this interface. Okay, and that will also get reflected back and come back after a second time. So based on this, our echo probe can actually form along a line a series of, or the brightness of which is determined by the intensity of the returning sound wave. Now, how much of a sound wave is reflected actually depends on the acoustic impedance of the tissue from which it is coming in and the tissue into which it is going. So if the acoustic impedance of the tissue from which it is coming, the Z1, the acoustic impedance of the second tissue, the tissue into which it is going, is Z2, then the amount of the amount of energy that is reflected is proportional to Z1 minus Z2 divided by the sum of the two. Okay, so this is how we calculate how much of the wave is reflected back. Okay, similarly another thing will happen at this interface. So if this is Z3, then the amount of wave reflected back will be Z2 minus Z3 divided by the sum of the two, so Z2 plus Z3. Okay, so that is how we come up with B mode or brightness mode acquisitions. Okay, and like I've already said, I'll be going through this in greater detail subsequently. In Doppler, what we do is we actually are measuring we are trying to visualize a moving structure. Okay, so that in this particular example, the structure is moving away, but the structure could be moving towards the probe also. Now, such movement by this structure is actually at a velocity much lower than the velocity of the ultrasonic wave that we are passing through the tissue. Okay, however, the relative velocity difference between the ultrasonic wave and the structure that is moving away or towards the probe produces a change in the frequency of the wave. So that change in frequency is what we have represented as delta nu, and the initial source frequency is our nu s. Okay, so the change in velocity can therefore be calculated, and I can actually calculate this velocity based on the shift or change in the frequency that was sent, that is the source frequency, and the frequency that we received back, on the difference between the two. Okay, so basically B-mode ultrasound allows us to measure the amount of reflection of waves at different tissue interfaces, and based on that make a brightness diagram along single lines, and then each one of those lines is stacked right next to each other to form a two-dimensional image. Okay, and a Doppler ultrasound allows us to measure the velocity of a structure moving away or towards the probe based on the shift in or change in frequency of the sound wave that is reflected back from that structure. Okay, and there's another mode which is actually an older mode but needs to be understood a little bit more. So that we call the M mode. Okay, so what do we do in the M mode? So M mode is basically just like the B mode. Okay, so we're making differences in the amount of amplitude waves that are reflected at different times and therefore different distances into the tissue, representing it along a line. But what we do is we then take that line, plot it along time. So we can actually take this line, shift it to the left side. Okay, that forms our x-axis, and then we make the time our y-axis. So what we do is along time, the distance from the probe may be changing. Okay, so this is particularly useful when something is happening in a cyclical manner. So for example, if time moves along, your mitral valve leaflet is moving towards the probe and then away from the probe. Okay, and the probe is positioned such that during the systole, the mitral valve leaflet is moving towards the probe. So this would represent our systole. And during diastole, it is moving away from the probe. So this will end up representing our diastole. Okay, so this allows us to see how over time during each cardiac cycle structures are moving away or towards the probe. Okay, so that's your M mode. Now what we've understood is that ultrasound techniques allow us to measure something. Okay, so what is that something? We have M mode ultrasound and B mode ultrasound. Both are show the amount of wave reflected and therefore the distance from the probe. Okay, so we measure the size of structure, the actual distance between two tissue interfaces. Whereas with Doppler, whether it be tissue Doppler or it is something called pulse wave Doppler, continuous Doppler, we are measuring velocity. Okay, tissue Doppler is calibrated so that it measures the velocity of movement of tissues towards the probe or away from the probe. Okay, similarly, pulse wave or continuous Doppler is calibrated such that the velocity of movement of the blood of structures towards or away from the probe, but non-tissue structures, that is blood, fast moving structures. Okay, so based on this, we can actually derive a few parameters. What are those parameters? So based on the size of structures, if I compare systole to diastole, I can check the change in dimensions of a structure between systole and diastole. Okay. Similarly, if I measure the velocity of tissues, I can use it as a surrogate marker for contraction or relaxation of parts of the myocardium. Okay. Thirdly, I can use pulse wave or continuous Doppler to actually measure the velocity of blood flow across a particular orifice. Now, this velocity can, using our modified Bernoulli equation, be used to estimate the pressure gradient, because the pressure that is pushing the blood, okay, so P1, okay, minus the pressure that is pushing against the blood flow is equal to actually the kinetic energy that is being produced. Okay, so usually we use this between chambers that are on the same height, so the potential energy difference doesn't really make any difference. Okay, so essentially this pressure gradient becomes equal to the half of the density of blood, okay, half of the density of blood rho, okay, times the square of the maximum velocity. Okay, so this is the maximum, so this is the work done, this is the work done and this will become your kinetic energy component of the modified Bernoulli equation. Now this simplifies actually to around 4. So it becomes, the pressure gradient between the chambers becomes 4 times the maximum velocity of the maximum velocity, okay, maximum velocity the jet squared. Okay, now let's use this information or this understanding of what we are actually measuring with the Doppler probe or the ultrasound probe to derive measures that reflect left ventricular systolic function. So when we measure, we want to represent left ventricular systolic pressure. What do we actually want to measure? Okay, we actually want to measure this part of the cardiac cycle, this part. Okay, and what do we want to measure in that part of the cardiac cycle? We first want to measure the difference in volumes, okay, between end diastole and end systole, because that gives us an idea of the ejection fraction. Okay, now we'll see how we estimate that using various parameters. So obviously the left ventricle is a 3-dimensional structure, and when we make our ultrasound images, they are 2-dimensional images. So a 2-dimensional cut through a 3-dimensional structure is unlikely to represent it very well. Okay, however, there are some parameters that do reflect it reasonably well and that can be used clinically. Okay, so the next thing that we're going to do is we're going to actually measure the velocity with which the mitral annulus, see, this is the mitral valve and these will be the two sides of the annulus. One will be the septal side of the annulus and the other will be the lateral aspect of the annulus. So how fast that annulus is being pulled towards the apex during the systolic component of the ventricular contraction. Okay, then what we'll do is we'll directly measure the velocity with which the blood is being pushed out of the left ventricle into the LV outflow tract. Okay, so these are the 3 parameters essentially that we will use to model our left ventricular systolic function. Okay, now let's start with the first thing, that is the assessment through measurement of dimensions. Obviously the dimensions will be diastolic dimensions versus systolic dimensions. Okay, and naturally we'll be using the M mode and the B mode ultrasound based techniques. Okay, because they are the ones that measure dimensions or size. Okay, now the geometry of myocardial fiber arrangement actually varies from the subendocardial myocardium to the subepicardial or subpericardial myocardium. Okay, in the subendocardial myocardium, there is a right-handed helix. How you think of it is basically you hold it with your right hand and your fingers will be parallel to the direction of the fibers. Okay, so that is a subendocardial myocardium. Then in the mid myocardium, the fibers are almost concentric. Okay, and in the subepicardial myocardium, the fibers are in a left-handed helix pattern. So if I was to hold the myocardium with my left hand, the fibers would be parallel to my fingers. Okay, so now the thing is that these fibers don't contract simultaneously. The depolarization wavefront reaches that particular myocardiocyte, and the depolarization wavefront actually goes from the endocardium to the epicardium, and then the repolarization happens in the reverse direction. Okay, so what ends up happening is that your subendocardial myocardium is the first to start contract. Okay, so when it starts to contract, there is actually a pull. It tends to pull the apex towards the base. Okay, there is a little bit of radial contraction, but not a lot. So initially there is a pull towards the apex, from the apex towards the base, but there is a stretching of the subepicardial myocardium. After that, there is a radial contraction of the diameter of the mid myocardium as the mid myocardial fibers start to contract. Okay, then eventually the subepicardial fibers start to contract. Okay, so there is a initial stretching of the subepicardial myocardicytes and eventual contraction of the subepicardial myocardicytes, resulting in a twisting motion. That twisting motion results in a decrease in the dimensions of the left ventricle, like this. Okay, towards the center of the left ventricle, and also essentially the apex and the base move closer to each other. Okay, so these are the dimensions that we will be measuring. Okay. So in order to visualize them, we have some standardized views where the probe is placed. Okay, so the first view is what is known as the parasternal long axis view. Okay, so for the parasternal long axis view, we probe in the fourth left intercostal space, and then the pointer of the probe is pointed towards the right shoulder of the patient. Okay, now for the second, this is known as the parasternal long axis or the plaques view. Okay, then we rotate the probe 90 degrees, okay, in a clockwise direction, so that now the pointer is pointing towards the left shoulder. Okay, at this point it cuts through the left ventricle in a perpendicular fashion, perpendicular to the long axis of the left ventricle. So now it is known as the parasternal short axis. Okay, so this is the parasternal short axis, and eventually what we'll do is we will take this probe, the parasternal short axis, we will move it towards the apex of that. Okay, and then start angling the probe such that the wire of the probe is moving, posteriorly and leftwards. Okay, so in that way we'll start getting the four chambers of the heart. And see, if you go a little further up, you will start seeing the LV outlet also. So that is then called the apical 5 chamber, but this is the apical 4 chamber. Okay, so this is the apical 4 chamber. So that's your parasternal long axis, and that's your apical 4 chamber. Now in echocardiographic images, okay, each one of these views is going to produce very characteristic silhouettes. Okay, so this is the parasternal long axis, and I've labeled the right atrium, left atrium, the right ventricle and left ventricle. Often, as you can see, the right ventricle, you're looking at the left ventricle through the right ventricle. Okay, so that is something that you need to understand. In the parasternal short axis view, this is the left ventricle and this is the right ventricle. Okay, so by convention, whenever the probe is placed, the pointer is pointed towards the right side of the patient. That is why the right ventricle is coming on the right side. And in the long axis view, because it is pointed, the pointer is pointed upwards. Okay, that is why the atria are coming superiorly and the ventricles are coming inferiorly. Now finally, in the apical 4 chamber view, the view is such that the ventricles are towards the probe and the atria are away from the probe, and you see all four the chambers at the same time. Okay, so let's see now, based on this, what dimensions can we compare between systole and diastole. So what are the measurements that we can take? There are actually 4 measurements that are taken. The first thing is fractional shortening. The second one is fractional area change. Then the third is mitral annular plane systolic excursion, and finally we have E-point septal separation. Okay, now these 3 actually reflect actual shortening in different axes. Okay, E-point septal separation reflects both systolic contraction and relaxation. Okay, but it does, through a regression formula, correlate with the ejection fraction, although not very exactly. So we'll come to that. Okay, now fractional shortening, what we do is, as you can see, we've used this is the parasternal short axis view, and in the parasternal short axis view you can actually see the right ventricle and this will be the left ventricle. Okay, and this is the parasternal short axis view at the level of the papillary muscles. So these are the papillary muscles. Okay, so we've gotten our orientation. Once we've oriented ourselves, we put a M mode line, okay, passing parallel to the LV short axis. Okay, and then we, as we've discussed just now, we plot it against time. Okay, so this is position of different components against time. So the first, as you go from here till here, the components that come up are obviously first the free wall of the RV, then we come across the septum. So this is the septum and this represents the septum, and then we come across the posterior wall of the LV, and this is the posterior wall of the LV. Okay, and as you can see, as time goes by, this during systole and during systole and then again during diastole, there are movement of structures towards each other and away from each other. So naturally, the systole starts after the R wave in the ECG. So as the systole starts, there is a maximum contraction, and this is the end systolic diameter of the internal diameter of the ventricle. And again, if I was to continue this would become the end diastolic diameter of the ventricle. Okay, so what we do is we find the difference between the LV end diastolic diameter and the LV end systolic diameter, and then divide it by the LV end diastolic diameter. So that is a fraction or a percentage, and multiplied by 100, so make it a percentage, and that represents our fractional shortening. And fractional shortening is basically what? It is a marker of the radial contraction that is occurring. Okay, but again, we are taking a one-dimensional cut through a two-dimensional slice of a three-dimensional structure. Okay, so obviously it's not a very sound measure, but it does give you an idea. Okay, and this will be seen in the parasternal short axis. Now the next thing that we're going to see is the fractional area change. Okay, so now we're going to take a two-dimensional slice through a three-dimensional structure. So although it's not very clear here, this is the apical four-chamber view. Okay, and this is the RV and this is the LV. Okay, so clinically actually usually we get such views, so it's not that odd. Okay, and what is happening is during diastole there is a very large area, and during systole there is a shortened area. Okay, so you measure this area through planimetry. Okay, the change in the area at end diastole, that is LV end diastolic area minus the LV end systolic area divided by the LV end diastolic area gives you the percentage change in area between diastole and systole. Okay, so again that represents volume, but as you can imagine, because it is because of the shape of the LV, if you angle it a little bit up or down, there will be a significant change in the values that you get. Okay, so it's not a standalone good idea to just measure the fractional area change. Okay, so this will be measured in the apical four chamber. The next thing that we talk about is the mitral annular plane systolic excursion. Okay, so it sounds very fancy, but it's actually a very simple thing. So this is your LV. Okay, this is the subepicardial myocardium, and this is the subendocardial myocardium, and this entire myocardium is actually attached to the annulus of the mitral. So this is the annulus. So when the ventricles contract, the annulus is actually pulled towards the apex. Okay, so this pulling of the annulus towards the apex can actually be measured. Okay, we can actually measure how much it is being pulled. Okay, and that would be a distance. So that will be in millimeters. Okay, so that is actually what is represented by the mitral annular plane systolic excursion. So how much does it move in systole? So the higher it is, the better is the systolic function. The lower it is, the worse is the systolic function. Okay, so again what we have done is we've taken an apical four chamber view. This would be the RV. Okay, so the probe is placed like this, and this is the pointer of the probe. Okay, so the pointer always points towards the right, that is why the RV comes to the right. Then this is the LV. Okay, so this is towards the left. Okay, and this is essentially like you're viewing the patient through a cut section, and we are viewing from the bottom up. Okay, so that is your RV and your LV. Now we put an M mode through the lateral part of the annulus of the mitral valve. Okay, so after we've done this, we have then plotted the distance between structures against time. Okay, so obviously the annulus moves towards the apex, so this will become the apex and this will become the base, and the annulus moves towards the apex during systole and moves away during diastole. So what we do is we just measure the amount of distance between how much it moves between diastole and systole. So this is where it was in diastole, and this is the maximum it moves in systole. So the distance between these two gives you your MAPC. Okay, now see, the thing is, this is how it is measured, but there are a lot of technical details. So all of these procedures, these are like extension of your physical exam. So they come, you get better at it by practice, and obviously it's very unlikely that routine practitioner will ever, unless they're doing it on a regular basis, they will ever be as good as a cardiologist. But what I want you to understand from how to interpret these findings, because the patient will come to you with this report, and often that interpretation in the context of your patient's clinical history and physical examination becomes very relevant. Okay, so if your MAPC is more than 10, okay, that means that the ejection fraction is more than 55% with a positive LR of 7. So essentially your postage odds become 7-fold better. Okay, whereas if you have got a MAPC less than 8, okay, there that it estimates an LV ejection fraction of less than 50% with a positive odds ratio of 5.4. So the odds become 5.4 times. Okay, so lastly, MAPC less than 7 with a LV end diastolic diameter, okay, of more than 60 millimeters. Okay, indicates an ejection fraction less than 30% with an LR positive of 3. So actually, if you look at it, MAPC is best at saying that a patient has adequate ejection fraction. Okay, it's not as good at diagnosing a reduction in ejection fraction. Okay, so that is something that we need to be careful about while interpreting MAPC. Okay, so it has a high negative predictive value for reduction in ejection fraction. Okay, now coming to the last parameter of in dimensions, so that is their E point septal separation. Okay, so this is done in the parasternal long axis view. So here we see our RV, okay, we see our LA, the left atrium, and we see the LV. Okay, we see here LV. So the LA is emptying into the left atrium, and then the blood is pushed into the aorta. So that is your parasternal long axis view. Now in the parasternal long axis view, what we've done is, again, because we want to measure distance, we placed a M mode probe across the mitral valve leaflet, okay, the tip of the leaflet. Now what we see is, as we pass through, first we see the free wall of the RV. So this is the free wall of the RV. Then we see the interventricular septum. This is the interventricular septum. Okay. Then we see the mitral valve leaflet. Okay. So this is the mitral valve leaflet silhouette. Okay. And then finally we see the posterior wall of the LA and LV. So this will be the posterior wall of the LV actually, base of the LV. So that's, once you got your orientation correct, these structures are then plotted against time. And we know during diastole there is an early rapid filling. So the mitral valve moves, from our discussion in S1, moves very far into the left ventricle. Okay, and that we call our E wave. Okay, or your early rapid filling. Okay, so that this is your E wave. And then as the blood, and that is under a negative pressure due to ventricular relaxation under normal circumstances. Okay, so after that, as blood fills into the ventricle, the negative pressure comes back almost to 0, and then there is a diastasis. Okay, then after that the atrium contracts, and that is what we call the atrial contraction wave or the A wave. This actually represents what? It represents two things. It represents strength of ventricular contraction and then relaxation. So E point septal separation is actually mathematically using a regression formula related to the LV ejection fraction. Okay, and it is not that reliable also. Okay, but it is a reasonably good marker, so we do use it. So the ejection fraction is given by 75.5 minus 2.5 times the EPSS. Okay, so this is the formula that we use, and based on that we can do it. Now the more number of methods you use to estimate the ejection fraction, the better it is, and the best single method is what we know, it's called the Simpson's biplane method. So in this method, what we do is we take an apical 4-chamber view, making this the RV, this the RA, this the LA, and this the LV. Okay, then what we do is we trace a marker from the septal aspect of the mitral annulus to the lateral aspect of the mitral annulus. Okay, and then we measure the distance from this to the apex of the heart. Okay, and then we have to essentially follow the endocardial lining all across to get an idea of the area. So what are we measuring? We're measuring length and we are measuring area. Okay, based on this, there's a regression formula, and we calculate the LV end diastolic volume. Okay, so the LV end diastolic volume in this situation is given by 5 times the area, which is again we measured, times the length divided by 6. Okay, so this is measured in diastole, and then again it is measured in systole. So the difference between the LV end diastolic volume and the LV end systolic volume divided by the that is the stroke volume divided by the LV end diastolic volume times 100 will give you your ejection fraction. And this is actually the best method because it is taking a two-dimensional cut through a three-dimensional structure. Okay, so if you have done it as per protocol, and I'm not going into the intricate details of the protocol because that is not my aim. The video is not, it's outside of the purview of the video, but you must understand a bit of the methodology. Once it has been done correctly, and there are many sources on the internet that can help you understand the methodology, and the best sources obviously go to your cardiology department and ask get assistance from an experienced cardiologist or echocardiographic technician. Okay, so based on this method we can easily estimate the ejection fraction. Okay, so this is your estimation of ejection fraction based on alteration in dimensions of the left ventricle between systole and diastole. Okay, now next we use our Doppler techniques to estimate velocity of movement of structures. Okay, so obviously since we are assessing systolic LV function, we are going to talk about systolic velocities. So we are going to first talk about the tissue Doppler based techniques. Okay, so this is your 5-chamber view of the left ventricle, and this is your RV, this is your LV, this is your RA, and this is your LA, and this is the LVOT, actually the aorta, the root of the aorta. Okay, just for orientation. So the probe has been kept on the patient. I'm looking at the patient as if I've cut through the patient and looking from below. Okay, now what I see is that the probe has been kept on the apex. Okay, now I put a probe, a tissue Doppler probe line at the lateral annulus of the mitral valve. Okay, and I plot the movement of this mitral annulus towards or away from the probe against time. Okay, and what do I see? I see this curve. Okay, so this curve corresponds obviously to different parts of the cardiac cycle because the mitral valve position varies according to parts of the cardiac cycle. So during isovolumetric contraction, it is this phase. Okay, there is a contraction of the ventricle, so the apex pulls the mitral valve towards itself. Okay, so velocity is reached towards the probe, so you get a positive deflection. Okay, then we have our ejection. Okay, so during ejection the ventricle continues to get smaller in size, so the mitral valve is again pulled towards the apex. Okay, and please remember this is velocity, not distance. Okay, so velocity, at a greater velocity it is pulled again towards the it accelerates towards the ventricular apex, and therefore you get this wave, and this wave is what we call the S prime wave. Okay, then during your isovolumetric relaxation phase, again there is a relaxation. Okay, but that relaxation, like I said, happens first in the epicardium, then in the mid myocardium, then in the epicardium, then in the then in the subendocardial myocardium. So again there is a slight positive deflection. Okay, and then finally we come to our diastole. Okay, so this is your diastole, and we will discuss this in great detail in the next class, next video. So during early diastole there is rapid filling, so that corresponds to the mitral valve moving away from the ventricle as the ventricle dilates. Okay, producing a negative pressure between the lumen of the ventricle, and that is what we call the E prime wave. Okay, so that corresponds to the early rapid filling. Okay, and then we have your diastasis. During diastasis, obviously ventricular dimensions are not changing, so the mitral valve is neither pulled towards or away from the probe. And finally, again during atrial contraction, the atria are contracting, so they're pulling the mitral leaflets away from the probe. So as a result, there is a negative deflection. Okay. So I hope this tracing is clear to you and how it correlates to the cardiac cycle. Now this is the actual tracing. What we've done is we've actually taken an apical 4-chamber view. We've actually in this tracing, however, the line of interest has been placed on the septal mitral leaflet. You can do either. The cutoffs are slightly different. That is the only thing. Okay. Now again we see isovolumetric contraction. Okay, followed by an S prime wave representing ejection, followed by isovolumetric relaxation, followed by early rapid filling, then diastasis, then the atrial contraction, the atrial kick. Okay, this represents a one systole followed by one diastole. Okay, now what we want is actually the peak velocity that with which the myocardium is pulling the mitral annulus towards the apex. Okay, so we want to estimate this. So we measure that, and what we find is that this is a direct marker of longitudinal contraction. Okay, so the normal values depend on the age of your patient. At less than 40 years, the normal S prime value in meters per second is more than 6.4. Then between 40 to 60, it is more than 5.7, and more than 60, it is more than 4.9. Okay, so these actually values differ based on guidelines. Different societies give different guidelines. These are actually your British guidelines. Now, however, generally value above 6 to 7 is normal. Okay, now we're going to assess the use Doppler to assess the LV outflow velocities of blood, of the jet of blood that is being pushed out by the LV into the aorta. So for this, we can actually use a very interesting technique, that is the velocity time integral. Okay, so what we do is we visualize the LV outflow tract using an apical 5-chamber view. Okay, and in that apical 5-chamber view, we place a in this case we placed a pulse Doppler line of interest on the apical 4-chamber at the LVOT, or that is the root of the aorta. Okay, so what we find is blood is during systole moving away from your probe. So your probe is here and the blood is moving away. So systolic velocities will be represented as negative velocities. So during systole, there is a probe, blood is moving away from the probe. Okay, so this represents your systole. Okay, so what we do is we actually trace the silhouette of this curve. Okay, so see, each line here represents the velocity at a given time t. Okay, so basically what we find is that if you integrate under this curve, what you end up getting is the velocity times the time. Okay, now velocity times time is obviously a distance. Okay, so if say we approximate the blood that is being pushed out of the aortic valve, okay, as a cylinder, okay, velocity times time, the integral of that will be equal to the length of the cylinder, the actual length of the cylinder. Okay, and we can also measure the diameter of the signal, okay, of the cylinder. Okay, so we can use this to measure the diameter. This is the diameter, and obviously half of the diameter will be the radius. So once we take the radius, we know the area. So I know the area of the base of the cylinder, and I know the length of the cylinder. So this is, if I multiply the two, area into length of the cylinder, I get the volume, actually the stroke volume. Okay, so that becomes your stroke volume. So your volume time integral is the length. Okay, your 22/7 is obviously pi times the LVOT diameter divided by 2, and this is actually squared. Okay, so that's a slightly wrong. Okay, this is in the apical 4-chamber. Okay, fine. Now the last parameter that we use is what we call the pressure over tangent time, using your mitral regurgitation jet velocity. Now for this, there has to be a mitral regurgitation jet. If it is not present, this parameter cannot be used. Okay, so what we do is put our pulse Doppler or continuous Doppler probe on the mitral leaflet or the mitral orifice, and then we see during systole is there any regurgitation jet. Okay, so the flow is again away from the probe, so you can see that the flow is negative. Okay, and during diastole there is positive flow towards the probe. So that flow, this is actually your E wave, and then after that you get your A wave. Okay, so this is your silhouette. It's clear. Now here what we do is we divide your mitral valve regurgitation jet into the first second, the second second, and third second, because this axis is time. Okay, and then we assess the the velocity at the end of the first second till the velocity at the end of the third second. So around for 2 seconds we are measuring the velocity, the difference in velocity, and we know from the modified Bernoulli equation that delta p is equal to the 4 times the velocity squared. So the pressure at v1 would be equal to, or whatever is the baseline pressure, that minus that, so p0 is equal to 4 into v1 squared. Okay, and p2 will be, or p3 will call it, okay, minus p0 is equal to 4 into v3 squared. Okay, so what will end up happening is I can actually measure the difference in pressure, or the dp, based on the difference between these two. So the dp will be equal to 4 times the v3 minus v1 the whole v square minus this thing, not the whole square. Okay, so based on that I can actually calculate the change in pressure. Okay, and obviously this is over 2 seconds, so I then divide it by 2. Okay, and I end up getting a parameter, that is your dp by dt. Okay, so obviously your dp by dt, the stronger the ventricle, the more pressure change it can produce in the first, in the second, and the third second of systole. Okay, so that is why we use this parameter, and I hope that is clear. Now, however, please, very importantly, this requires a mitral regurgitation jet to be present. Okay, and this is in the apical flow chamber. Now, dp by dt, that is more than 1200 millimeters per second, mercury per second, implies a normal ejection fraction, and less than 800 implies a low ejection fraction. Okay, so that brings us to the end of our talk on the assessment of LV systolic function. However, see, this is not intended to be a very rigorous discussion on all of the methods to assess systolic function, although I've covered most of them. What I want you to understand is how it is interpreted. Okay, so when you read the actual report, which we'll come to in the once we go before in the video, before we delve into the actual pathologies and their release scripts and their imaging, at that point I'll be giving your echo parameters, and we'll interpret them without actually doing the echo ourselves, because often as internists or as rheumatologists or infectious disease specialists or hematologists, we see the report rather than actually see the echo being done. Okay, so the interpretation is very important, and it requires some understanding of the physical principles and the methodologies that are being employed to assess the ventricular function. Okay, so this concludes our discussion on assessment of LV systolic function. We'll use similar principles to assess LV diastolic function subsequently, and then we will move on to assessment of RV function before, like I said, we come to the assessment of individual pathologies that cause chronic shortness of breath.